say with the apologies. And I think, Madeline, you said Guy?
Councillor Grandison.
Did Malcolm turn up for substitute or?
Not at present.
No. Well, in that case, let's go to the minutes of the previous meetings. Now, the two meetings we're agreeing tonight. The first one was held on the 21st of September. Is everyone in favour of those, or does anyone object to those minutes?
I would just like to ask a question, Chairman, if I can.
Okay. Normally we accept them first and then we ask the questions afterwards, but no, I don't think it matters. Yes, go on, Jim, go ahead.
Okay, page 13, there was a request by myself about ambulance response times. I just wondered whether that report had been progressed at all.
I'm still waiting for a response, but I will chase that up for you.
Okay, lovely. Thank you, Madeline. Thank you, Chair.
Okay. So we're okay to put that one through. And then we had a second meeting.
Oh, sorry, Chairman. Can I just say I did have my hand up? Sorry, I wasn't a member of the committee at that time, so I won't be voting on it. And the previous one, I was not present either, so I won't be voting on either of them because I obviously wasn't there.
Is this the first one you've come to then, Michael?
It is indeed. I couldn't do the other one. I had a clash.
Extra warm welcome.
It's my first ever Health and Overview Scrutiny Committee meeting.
Is that right?
In all these years.
Oh, well, I feel yeah, we've got.
So it's quite momentous. Yeah, thank you, Chairman.
Cheers. Okay, October the 19th was the next meeting. Everyone in favour of that? Oh, we have. Was that Clive trying to? No. Okay, that's great. Anyone object to those meetings? Those minutes? Sorry. I don't see any hands. I take that as accepted. We then move on to declarations of interest. Anyone got any declaration? Jim, I can see a hand.
Yes, Chair, same interest as I declared last time. I have a relative that works at the RBH and I also operate as a volunteer first responder. So.
Okay, brilliant. That will be recorded. Any public questions?
I've got a declaration of interest, Ken.
Oh, go ahead, go for it.
Yeah, I'm a governor of the Royal Berkshire Hospital Foundation Trust and also have a family member who works there. Thanks.
Okay, thank you. Okay, we move on from declarations then and we go to public question time. Madeline, are there any?
Sorry, no questions.
Member question?
No questions.
No questions. In that case, we can now go straight ahead to the Royal Berkshire Hospital, which is item 33.
Thank you very much, Ken. I should just introduce myself to begin with. My name's Dom Hardy. I'm the Chief Operating Officer at the Royal Berkshire FT. Many of you have already, in the declarations of interest, indicated some of your relationships with the organisation, and I know it's got a central place in our community. I thought I'd just spend a few minutes this evening just outlining a few key points about where we're at the moment and a perspective on the services that we offer. And then, Chairman, I'm very happy to take any questions really that members may have and to discuss the points that colleagues want to raise. Would that be acceptable?
I think that will work well. Is anyone disagree with that? Oh, no hands. Please go ahead.
Thank you. The place I'd like to start is by thanking, perhaps through colleagues on this committee, residents and local organisations, large and small, from the borough for all the support that you gave us during the first wave of the COVID pandemic. I'm not sure we've registered those thanks formally as an organisation, so I thought I'd take the opportunity to do that. It came in the form of people simply doing the right thing, people making donations, organisations providing gifts like free food, as well as some services and other goods. And we are, or continue to be, intensely grateful for that sense of solidarity with us while we're going through such a busy time. It definitely buoys up our staff. So I would just extend our organisation's thanks to you on behalf of your population for all that help. We are now, having come through that first wave, fully open. All of our services are running. That means that we're, of course, taking all necessary safety precautions to make sure that through use of PPE and other measures like social distancing, we're making our services available in as secure a way as possible. And we are keen that patients do attend their appointments whenever they're invited. They may have reservations. We know from speaking to many of them that they might have anxieties or lots of questions about their care, and we aim to answer all of those. But if, on behalf of your residents, you have other concerns, I'd very happily answer those. Equally, if you have suggestions about how we encourage people to attend, things that we're not doing already, I'd welcome any thoughts and ideas. We've got three aims as an organisation over the next few months during the winter period. The first is, of course, to deal with whatever COVID activity, however many patients suffering from COVID need hospital admission. At the moment, those numbers are nowhere near the levels that we reached at the peak of the first wave. While we can see projections of increased prevalence in the community, we're not at this point seeing a real surge in hospital admissions in the way that we did during the first wave. And that's enabling us not only to meet the first aim that I identified, but our other two aims as well, which are fundamentally to continue to provide urgent care to patients who need it, who are not necessarily suffering from COVID. That might mean strokes, heart attacks, for example, other people who present at our emergency department, and will continue to do so during winter, whether it's through seasonal illness like respiratory disease, or perhaps even flu, as that maybe takes hold in the community. And our third goal, our third aim rather, is to continue to treat patients who are sometimes described as needing routine care, but in my view, that can sometimes mean patients who've been waiting a long time for treatment or for their appointment, and may well be in pain, having waited perhaps longer than we would ideally have liked. As I said, at the moment, all of our services are running normally, and so we are making inroads, making progress towards treating the backlog of patients that accumulated during those few months when we were not able to provide all of our services. And I'm pleased to say that we're meeting overall the objectives that are set by the regulator, NHS England and Improvement, for our recovery over this autumn period. And we will continue to sustain all of those services for as long as it's safely possible to do so. I suppose I'd just close my opening remarks by saying we've also been able to sustain other major pieces of work as we've gone through this period of recovery and preparation for a second wave of the pandemic. And that includes, but isn't confined to, work towards creating a strategic outline case for a new hospital development. Members may be familiar with that process. If not, there's still time to contribute through our website and a specific microsite thereon. But in essence, we're required to submit a strategic outline case with a wide range of options for potential future hospital development. At the moment, those options include a range of options for redevelopment on the current Royal Berkshire Hospital site, and also an option for a fully new development on a brownfield site. If we're successful in convincing central government that we have a solid strategic outline case, we'll go forward to an outline business case, and we hope then to a final business case where we hope to secure our share of whatever national infrastructure is funding it is made available at that point to healthcare providers in the NHS. It's almost certainly going to be a major preoccupation and priority for us, and we hope our partners in the community over the coming years. I just invite you, if you haven't already, to take advantage of the opportunity to have your say, whether as a formal committee or indeed as individual members, in the work that we're doing, even at this relatively early stage in that process. Let me close there, Chair. And as I said at the outset, I'm very happy to take any comments, questions, or challenges members may have.
First one I'll ask straight away is, I think the questionnaire that was up on the site is now closed. I think that closed last week.
Yes, all I'm saying is there's an opportunity to continue to submit views via this meeting or offline to me, and I'll make sure they're entered into the process.
Good to know. Great. Hands up. We've got Jim first. Jim Farine.
Thank you. Dom, I know you thank the community, but that works both ways. We should thank you, because I know some of the hard work and some of the pressures that were experienced there, not only firsthand but also secondhand. So thank you to everyone there. We hear a lot in the news and the papers about how COVID is affecting services. So I just thought I'd give a couple of bits of positive feedback. I've unfortunately had in the last few weeks 2 friends that have had forms of cancer, which have been treated efficiently, very speedily, and let's hope effectively by the guys at the RBH. So again, there's a good news story there, so thank you for doing that. I've got a bit of a strange question. You talk about the potential development. I understand you had a visit from Boris and he had a bacon sandwich. How did that go, and is that going to influence anything we're going to get as a new hospital locally?
He did indeed. 2 weeks ago, he paid a visit, I think ostensibly to make an announcement about a review of hospital food. He visited with Matt Hancock and Prue Leith as well, who I think has been engaged to help the government with that piece of work. You can imagine that we took the opportunity to talk to him about the work that we're doing, to thank his government for including us in the health infrastructure programme number 2, and to make sure that we really impressed on him the need for investment in the infrastructure, which, as many of you will know, on the Royal Berkshire Hospital site is not always in excellent condition. So it was a good meeting of minds. I wasn't there myself. It was an even more select gathering, but he was enthusiastic, and I'm told he was very engaged and supportive in the conversation.
Thank you. And one more, if I may, Ken, last one.
Of course. Go.
Later in one of the Healthwatch documents on page 28, we have some feedback from a patient, unfortunately in the maternity unit, which is my daughter works, that the communications letters that go out haven't been updated to reflect COVID. Right. I just wondered whether we should give that feedback on behalf of Healthwatch now, to say that some of those standard letters, I think, may need reviewing, because it does confuse patients.
That's really helpful feedback. Do you know, Jim, whether that was particularly in relation to visiting and who can attend with an expectant mother?
Perhaps the Healthwatch guys can provide that. All I've picked up is that comment out of their document, which comes a little bit later on, Dom. I haven't got the details.
That's really helpful. I will definitely get in touch with Healthwatch colleagues and double check exactly what that is. I should also just thank you again for acknowledging the work that our teams are doing, and I really do wish your 2 friends a speedy recovery from their cancer. I'm really pleased to hear that their treatment was efficient. Thank you.
Thank you very much. Thanks, Ken.
Okay, thank you. Michael.
Thank you, Jim. Yeah, thank you, Dom, for that. Like Jim, I like to express my not delight, but my full support of the NHS workers, my thanks to them as well over the last 8 or 9 months that this has been running. So I know it's all been difficult for everybody. So they're sort of one of the sharp ends of it. So, and I'm glad to hear about Jim's friends as well. So hopefully there'll be more success stories like that going forward. It's just really got you sort of touched on the backlog. And I'm just, this is about the $64,000 question, really. But when do you think RBH will catch up on the backlog? I know it's not going to be any like 5 minutes or something like that. It's going to be some months. But have you got any idea of sort of timescales there? I won't hold you to it or anything like that, but it would be interesting to know.
No, of course. I think it's a really good question, Michael. And I just, again, acknowledge your kind comments about the teams. I just say in many ways, we feel quite privileged. We realise that other members of society are in a really difficult position. We have jobs, often we're able to go to work and be with colleagues and have that social group. And so, you know, your comments are well taken, but I would equally just acknowledge that people have had a really rough time over the past few months. I could answer your question in a couple of ways, Michael, both of which would perhaps shed a different set of light on things. The very longest waiters that we have, those under the referral to treatment target, who've been waiting over 52 weeks, waiting a year, we expect on our current rate of working, and assuming that we don't have to suspend services because of COVID, we expect that number of patients to be largely eliminated by late spring, so April, May. At the moment, we have about 1,200 patients waiting that long, and you can imagine there's a hump of patients who were waiting in the very first part of this calendar year who didn't get their treatment, who are in that backlog. So if we continue to work at the rate that we are, we would expect that to be cleared roughly by April, May time. What I would equally say is that where patients have urgent need, so patients who are unfortunately diagnosed with cancer, we do expedite their treatment. So in no way do those urgent patients wait anywhere near that long. Jim will know how long his friends waited, but I would hope it would be a matter of weeks or even days rather than months. Even in the height of the COVID first wave, we continue to treat patients with cancers or other very urgent needs as urgently as that. And we will definitely do that, even if there is a resurgent second wave of COVID. I think that's just another way of answering your question about eating through the backlog. Our teams are working exceptionally hard at the moment, and we'll continue to do both of those, keep both of those focuses over the coming months.
Yeah, okay, yeah. I mean, I do appreciate that there'll be emergencies coming up, and I got a great number of friends who are nurses, and they all seem to be called Jenny. So I don't know why. That's a good name for. There's about 3 of them I know with the name of Jenny. So yeah. So thank you for that, Dom.
Okay.
Thank you, Michael. Clive.
Yeah, thank you, Ken. Hello, Dom. Thank you very much for that presentation. I think that you're all doing a very good job. All 5,000 plus employees. You've got such a lot, haven't you? I got a question about cancer treatment. I know that we're managing to keep up with the 2-week investigations and the month investigations, but are we going, if this second wave lasts 3 months, like the first one, are we going to be able to keep up with cancer treatment, cardiac treatment, stroke treatment?
And the short answer is yes. So we did manage to do that during the first wave for each of those conditions and presentations. In fact, there's been some speculation in the media that people did not choose to attend when they had a really urgent condition. But for example, for stroke care, our expert team did an audit, and they found that compared with the previous year, almost exactly the same number of patients with genuine strokes did attend even during that period. And you may well know that our stroke and cardiac teams are among the very best in the country in terms of the rapidity with which they treat patients who do present. They managed to sustain that even during the peak of COVID, which is just a phenomenal achievement. I would say also on cancer, what we've been able to do is, for those of you who've not visited recently the Royal Berkshire site, make sure that the Berkshire Cancer Centre is a very cold or separate part of our whole site and services. Separate entrance, temperature checked as you go in, even for members of staff like me, just to take those added precautions. And then absolute precautions taken by staff to make sure that patients potentially in a vulnerable condition are fully protected. We also give real focus to making sure we move people through their cancer pathway if they're diagnosed or referred undiagnosed as speedily as possible. And I've every confidence that will be able to sustain that, because we plan to do that. We've identified where we would, for example, continue cancer surgeries should we need to during a second wave, in a way that would make that surgery as cold as possible, as protected as possible, even if we had to suspend other planned surgeries. And I'm therefore confident, based on our previous experience and our future plans, Clive, that we'd be in a good place.
We have been making good use of the private hospitals around Reading as well, haven't we?
We've certainly made some use of them, yes. Berkshire Independent Hospital is helping with a number of our services, dermatology, plastics, some rheumatology outpatient work. We've done general surgery and orthopaedics at Circle, and during the peak of the pandemic, a lot of our haematology and cancer patients, our oncology patients, were at the Dunedin Hospital, Spire Hospital out on the Bath Road. Yeah, they've provided really good support, and we work well with them to make sure that patients can use their services should they need to.
Something for Healthwatch might be to ask those particular patients what they thought of their experience, because I would think that first of all they're going to be very grateful that you were able to use those other facilities rather than just having to come into the main site at the RBH.
Yes, in fact we get good patient survey feedback from all of the sites that we have. So even beyond the independent sector hospitals on our periphery in Reading, we've been able to make really full use of our facilities out at Henley Townlands Hospital, Bracknell Health Space, the Prince Charles Eye Unit, of course, out in Windsor, and at West Berkshire, where I was yesterday. Each of those facilities have been running as hot as they ever have in terms of the amount of activity going through them. And it's put us into an advantageous position, even compared with some of the NHS providers all around us, who simply don't have that range of facilities to use.
Okay, and then just one more question. You talked about either developing the site or you mentioned a brownfield site. What I've heard before has always been a greenfield site.
Well,
was that just a slip of the tongue?
I think it depends what people mean by greenfield or
brownfield site.
I think it depends how they would define brown or green. I suppose what I mean there at a high level is it's an option to develop a new hospital somewhere other than the very central landlocked site that we have currently off Craven Road. There's a bit of speculation about where that might be, but at this early stage, we're just not at the point of pinning that down. We're not asked to by central government. We're simply asked to make sure that that is one of the options that we properly record in the outline business case. Sorry, in the strategic outline case.
Yeah. When Nikki came last time or time before, she talked about becoming a teaching hospital, because I asked if that was one of our ambitions. So would that excite you as well if we were to become a teaching hospital?
Of course it would. I mean, we have to go through a whole process to do that, but the level of ambition, as you know, in our organisation is extremely high. So I can see that would appeal to a whole range of people. Yeah.
Okay. Thank you very much.
Thanks. Pleasure. Thanks, Clive.
Thank you, Clive. Rachel, you're next.
Thanks very much. I was wondering how you're expecting the Royal Berks will cope with the expected peak of the second wave in terms of capacity, and whether in a worst case scenario you might be expecting to look at kind of some need to overspill into other sites.
So definitely our escalation plans include proposals to use our other sites and potentially even use local independent sector providers should we need to. At the moment, Rachel, we're not seeing that real increase in cases and hospital admissions that we saw in the first stage of the pandemic. We had 10 days during the first half of September where we had absolutely no COVID positive inpatients at all. Then on the 14th of September, we had our first second wave COVID positive patient, unfortunately, and we've seen the numbers very gradually increase over the subsequent 2 months. But that increase has been nothing like the extremely rapid peak that we saw from very late March into the first 2 weeks of April. So yes, we've got contingency plans. They're at the level of individual specialties and teams, but they will only be enacted should we need to. And as I said, at the moment, we're managing through the skill of our teams and my colleagues in management to sustain all of our services in their usual configuration.
That's great. So hopefully the Royal Berks will be able to cope with any expected second peak without having to use other facilities.
So I definitely expect us to cope. When you say the facilities, do you mean hospitals or sites other than those that are within our trust at the moment, like Bracknell or Henley or West Berks, or do you mean hospitals elsewhere?
I guess I mean possibly hospitals either locally or elsewhere. Or I know that there was a possibility discussed in Wokingham of us using a hotel as a kind of an overspill facility during the first wave.
So I think that was a proposition around patients who had recovered medically, still needed to go somewhere. So a form of social care that was outside an acute setting like a hospital. I mean, certainly we've worked, I should acknowledge, we've worked very well, I think, over recent months with colleagues in the local authority. Matt Pope, your Director of Adult Services, I think has been particularly supportive. And that's enabled us, for example, to reach agreement with the Clinical Commissioning Group on supporting funding arrangements for local authorities, including Wokingham. So they've all got contingency plans like that in place as well, alongside our own plans. And we speak regularly to make sure that we're in alignment on those plans.
Fantastic. Thank you very much.
Thanks, Rachel.
Thank you, Rachel. Abdul, you're next.
Thank you, Ken, and hi, Dom.
Hi, Abdul.
Thank you for coming and appreciate it, what's been said so far. And our sincere thanks goes to your staff and everyone at the hospital who's working. My question relates to, a few of them already been you all said. The BME group in Reading and Wokingham, they seem to be very frustrated, and in a term of the moment they said, you are going for a COVID-19 test. So the whole of the household is just like so frightened to get into the hospital and so on. As you are very aware, that restriction is one of the problems for them to access the information between what's happening to their loved ones. I know there has been sadly, all people has been passed away. And as I am one of the members of the cemetery group, which burial, and there's quite a few of the mosque has came to me and saying, why is it so delayed to pass on the death certificate when it's COVID-19 related deaths? So I wonder if you could please touch on and give us some explanation why the delay is.
That's a very good question, Abdul. I'm not aware of the delays, but I'm very happy to take a look at that and find out what the reasons might be for any delay in the issuing of a death certificate. It sometimes does take a while our medical examiners do reach a conclusion about cause of death, but I'm not aware of any specific delays. Would you allow me to look into that and come back to you?
That will be thank you very much.
Abdul, do you know how long a delay that people are experiencing? Are we talking days, weeks, or?
Especially if it's if the death happened on Thursday or Friday, it seemed to be weekend is the most highly.
Yeah.
Yeah.
Thank you, Abdul. Cheers.
Thank you.
I'll take a look.
And can I come back to one more question?
Yes, please do. Yeah.
Yes. Dom, I know probably 10 years away, it was going to take 10 years to build a new hospital. Given the amount of people you are serving in Royal Berks Hospital, are you quite confident that you would able to cope with the COVID-19 if it increase, and also given these always deaths go up during the winter months? So what's your opinion that you would able to cope in terms of manpower and also about your nurses and doctors, because I know they also have COVID-19 and you have worried how you're going to sustain this. Thank you.
That's a really good question, Abdul. We've worked very hard to make sure we protect our staff as well as patients who come through our doors, and that includes making sure that we've got not just adequate supplies of PPE this time around, but at least 2 weeks worth in hand, if not several months worth. That gives a sense of reassurance to staff that they will be protected. We've also had notice, just like every other NHS trust in the country, of the rollout of what's known as asymptomatic staff testing. So we expect our staff within weeks to be able to test themselves with one of those new rapid tests that where the results are available within a few minutes. And that ought to identify staff who perhaps unknowingly are positive for COVID and therefore should not attend work, and will help us then avoid any kind of transmission between staff groups in the hospital, where we already take the social distancing and PPE precautions we should. We've seen a kind of steady, very slight increase in the number of staff who are off sick and have COVID, but the numbers are relatively small. And as in the first wave, we will make robust arrangements to cover for those staff where they are off sick. And we do have access to agency and other temporary staffing should we absolutely need it. So I'm confident, based on our experience in the first wave and the experience of our staff, that we will be able to withstand that kind of pressure should it increase to any great extent over the coming months.
Thank you. And one more question, if you don't mind, Ken.
Yes, of course.
Yes. Are you getting a larger number of school children who's been admitted from, especially from working borough school children, as a COVID-related symptoms?
No, very few. One of the very few good points about this virus is that it really does not seem to affect children to any great extent. Even if they're testing positive, very fortunately, they don't appear to suffer severe symptoms unless they have extremely extensive underlying health conditions. So we're not seeing that come through, Abdul, I'm pleased to say.
Thank you, Dom. Thank you, Chairman. That's very pleased to hear that.
Thank you, Abdul. Jim Froon.
Thank you, Chair. Tom, a couple of times you've mentioned the stage at which we are for a new hospital or a refurbished hospital, a strategic point. In one of the local press we had a couple of weeks ago now, Shinfield to expect a brand new hospital to be built there. I'm assuming from what you're saying, that's probably speculative press?
I think that would be a good word to describe it.
Thank you. I just wanted to confirm that. I will have a word with said press.
Yeah, so the process, just to be really specific, and this is all subject to Her Majesty's Treasury and the Department of Health and Social Care agreeing with us at the various stages. We have to submit 4 options in the strategic outline case, and a new build would be one of them. That gets narrowed to 2 options in an outline business case, which is the next stage, which would be 6 to 9, maybe 12 months away. And then, assuming we're successful, even at that stage, we go to a final business case, which is about 1 option developed in granular detail, again, a number of months after that. So the timetable feels, quite drawn out, but that's to allow a real level of scrutiny, both among us in terms of community partners and at the level of government, financially and in health policy terms. So that's how we would get to a stage where there was a single lead option, whatever that might be.
Okay, I will feed back my comments to the speculative press people.
Much appreciated, Jim.
Adrian, sorry, I missed you last time. I jumped ahead. Would you like to ask your questions?
Yeah, thanks a lot, Ken. Hi, Don. Firstly, thank you for all the support RBH has provided to all the residents over this very difficult period. We had a previous meeting with RBH, which I would say was a very successful meeting. and we definitely welcome your attendance to this meeting, and hopefully we can see you again, or somebody from RBH again. I think Abdul's question already talked, or your responses to Abdul's questions already illuminated one of the topics that concerns me. But I was listening to some information from another hospital, not RBH, where they were definitely having a lot of staffing, resourcing issues due to people testing positive for COVID, and because they were exposed on the hospital grounds to their teams, etc. Some of the teams perhaps having to go into isolation. And obviously a key aspect that was identified during that was quick and early testing. And I think they have these sort of tests that can be done in like 45 minutes or something. Do you think today that RBH has enough access to those very quick tests?
So that's a really good question. We do have access to what are known as point of care tests, or testing at point of care. We usually use those for patients who are admitted to the Royal Berkshire Hospital through the emergency department. So if an example would be if a consultant thought in ED that a patient might be positive, or actually almost certainly if they're going to be admitted, they'd have this relatively rapid test, get the results within an hour or two, and at least we'd know where they ought to go in the hospital so that they didn't infect other patients if they tested positive. We currently don't use that facility for staff because we reserve it for patients to make sure they're as safe as possible. At the moment, our staff have access when they need a test to staff testing, which we run through South Wing car park. It's the same facility that we ask patients to use when they have a planned procedure, and we normally get the results within 1 to 2 days from that service. But the program that I referenced a few minutes ago, the so-called, I think, LAMP test, I think gives a result within 20 minutes. So the idea that's been described to us is that someone would take a test maybe Monday and Thursday, maybe Wednesday and Sunday, depending on their shift pattern, but twice a week, and would know the result before they even came to work in the morning. You know, you'd get up, do the test, you'd then, you know, get ready, and then you'd see what the result was. And that would be, I think, a big advantage to us. At the moment, what we're reliant on is staff, if we detect a case, getting tested and then self-isolating. And we've been assiduous in making sure, particularly through our occupational health team, that we have traced staff who've been in contact with members of staff who've tested positive, and that's enabled us to get on top of any outbreaks that have occurred so far. There've been 1 or 2 minor ones, but we've managed to keep a lid on it, fortunately.
I think you've explained and given very comprehensive answers around your expectations for the future. But one area that also concerns me is individual outcomes. And I think this is essentially quite a good news story. I just wanted to get a bit of inside track from the front line, if you like, as to how COVID treatments had improved and enhanced people's outcomes from, say, the early stages of COVID.
We've definitely seen the science move on an awful lot. And you may well have seen in the media over the last few months reports of the use of dexamethasone, for example, a commonly available steroid that I think, while I'm not a clinician, I'm given to understand that when it's prescribed to someone in the early stages, it can certainly really help ameliorate their condition. Similarly, techniques like proning, where people lie on their front in ICU, or use the face mask, CPAP, continuous positive airway pressure, have all been innovations that we've, our clinical teams rather, have drawn out over time from talking to colleagues, not just in this country, but abroad, about some of their experiences. I think it's really, if I'm really honest, Adrian, I think it's hard to speculate at the moment about whether those interventions have really impacted on the outcomes that patients are seeing in this wave. We think that is true. We think that might be the reason for relatively few patients who are suffering from COVID being in our intensive care unit at the moment, compared with the first wave where there were a really significant number. But there may be other things going on that we're just not aware of yet, that the science hasn't identified. Maybe that the strain has mutated or something. It may be that it's affecting slightly different cohorts of the population. But definitely the expertise that our consultant-led teams have acquired over the last few months is definitely helping our patients right now.
And one final question. You talked about the supply side of PPE. One thing I saw on the news, not particularly in UK hospitals, but in other hospitals, was a potential shortage of oxygen because of all the patients being oxygenated. What's your supply side situation for oxygen?
It's very good. We are in the very fortunate position, through the far-sightedness of our facilities and finance team, of now being in the position to make our own oxygen. We invested during the first wave in the high-tech equipment to do that. We had the benefit of expertise from University of Reading colleagues, and we're now one of the very few trusts in the whole country, possibly the only one, I'm not absolutely sure, that makes its own oxygen. We are not reliant on cylinders being delivered to us or other such routes, and that gives us a tremendous advantage.
If I can just help you there, Dom, you were the first in the country.
Yeah.
Graham Sims, who is the chair of the trust, was very, very proud of that when he was telling us the other day.
Yeah.
And at that stage, you were still the only one.
I was going to say, I'm just not sure whether anyone's acquired the expertise. I was just hedging my bets, Clive, just in case I was over-claiming. But yeah, we were the first, and it is a
very proud of it.
Yeah, no, we were grateful for all the help we had with that.
Yeah.
And one final comment, if that's okay. I hope you showed Boris the heating and ventilation issues that the RBH has, and hopefully he really understands the investment that is required. And I certainly wish you well in your request to get really proper investment, and that's so crucial eventually for the long term of all the residents in this area, I would suggest.
It really is. One thing I ought to have said, although the kind of main investment for a hospital redevelopment is some years away, we've been given some money up front, and that's going to enable us to make some changes in this financial year. So some of you may be familiar with the dilapidated buildings on West Drive, just near the West Drive entrance. We're going to bulldoze those, and that's because we've been given a few million by central government to start advancing our plans and clear some of the frankly hopeless estate that we have. Equally, and exactly to your point about heating and ventilation, Adrian, that's very astute. We've been given, as part of that early money, investment to de-steam our site, which essentially means stripping out, I think, 3 miles of knackered old piping and putting in a wholly new heating system. It's going to cost millions, but we've been given that investment because almost come what may, that will be a really advantageous thing to have done on the Royal Berkshire Hospital site, and we'll get better heating as a result of it, and more sustainable and energy efficient heating, I would say.
Thanks very much, Dom.
Pleasure.
Right, Clive.
Yeah, thank you, Ken. I've got a couple of questions about the vaccine that's going to become available probably in the next 3 or 4 weeks. Are we ready as a hospital to be able to administer the vaccine, which I think is probably going to be given to NHS staff and people over 80 or 85 first? And if we're going to be giving it to NHS staff, are we going to be making them, as far as you can, make them have the vaccine, or is it going to be down to their personal choice, and will they be able to say, well, no, I don't want to, I don't feel that it has had enough testing, so I don't want to take it, and will we be relaxed about that as an organisation? Sorry, will you be organised?
We're ready to administer the vaccine to our staff. We'll be responsible for that dimension of the programme. It'll be general practice and others who'll be responsible for vaccinating the population outside the hospital staff. My understanding is that we'll be providing that vaccine on the same basis that we provide yearly annual staff flu vaccine. So we'll strongly encourage people to have their flu vaccine, their COVID vaccine, in the same way that we strongly encourage people to have their flu vaccine. We'll do that in a supportive way by providing as much information as we possibly can. But I don't know of any legal means that we'd use, even if we wanted to, which I don't think we would, to mandate the use of vaccine. I think this has to be about making people feel safe, secure, and to want the vaccine ultimately.
Yeah. What is the take up for the flu jab amongst your staff?
Yeah, we're over 70% take up this year, which is it's a new record for us. Yeah. And that bears really good comparison with any trust in the country. I would say I used to be the director in NHS England nationally, responsible for immunisation and vaccination programmes across the country in my previous role. My experience of that was that it took a number of years to build up really good uptake of different vaccines. So flu vaccines administered to staff in hospitals, that's not been going, for decades and decades, but the increasing focus on that over recent years has led to incremental improvements in rates of vaccination. We can only speculate about what will happen with COVID vaccinations, but I think it's likely we'll see similar, if not greater, levels of uptake, because I think people will rightly want to protect themselves, their families, and actually our patients from this horrible virus.
Okay, thank you very much. That's it.
Abdul.
Thank you, Chair. Dom again. My question relates to national supply chain. If after 31st of January, the backlog start happening, are you confident that we will have enough supply in the RBH? Because I don't know how much supply you get from Europe or elsewhere. Thank you.
So I think the statistic that I recall on this, Abdul, is that in the first wave, the NHS in England only received about 4% of its PPE supplies from manufacturers in Britain. And my understanding now is that is massively different, and that over 70% of our supplies are British manufactured. That in itself puts us as a country, never mind a single organisation, in a far more resilient and robust position. Beyond that, we've not only got our supplies and stocks in good order, but so has every other organisation around us, and there are stockpiles of PPE in kind of centralised locations for our wider healthcare system. So while we can't ever rule out problems in the future, I personally feel a lot more reassured and confident going into any second wave than I did at this point in the first wave.
Okay. Thank you, Dom. Thank you, Chair.
Thanks, everyone. A couple of questions on mine are slightly different. Accident and emergency, what actually happens when we have these COVID outbreaks? My understanding is it actually reduces quite a lot, especially if you're in lockdown. Is that correct?
We're seeing, it's a good question. You're right that in the first wave, we were only seeing about 2/3 of our normal attendances at ED. So on a usual day, we might have between 300 and 350 attendances at ED, sometimes slightly more. In the first wave, that was down to around 200. We're not seeing that fall in attendances this time round. There are probably 25 to 30 fewer attendances per day. So we're running at around 270, 280 per day at the moment. I can speculate about the reasons for that, but I'm not sure they'd be kind of data founded at this point.
Yeah. And the other one is that during the last COVID outbreak and this one, have we ever reached 100% of resources in use at RBH, or have we always been below the maximum you can take?
In terms of beds, Chair?
Anything, yeah. Did you ever say to yourself, we can't do this, we've run out of resources? Or was it always a case of, no, we can do this, we take them in, and it worked accordingly?
We were generally in a robust position. The only constraint that we ever had was over the Easter weekend, just like the rest of the country, where there was a well-publicised shortage of surgical gowns. And that was the only day, the Sunday and the Monday, when we were at risk of not having supplies that we needed. We did manage. We got through that. We had emergency deliveries. We have mutual aid from other organisations, and we managed through that period too. But that was the only moment.
Oh, excellent. Okay. There was one other question. I can't remember it now. You've escaped it. We have Nicholas Durban.
Yeah, hi Dom, it's Nick from Healthwatch Wokingham. There was a comment earlier on about maternity, but I would say in that report there's a huge amount of comments about the thanks from local residents for the work that was done by the people in the NHS. But it was just a question about phlebotomy and where that is at the moment in terms of capacity compared to pre-COVID, because we've had quite a few comments from local residents about phlebotomy services.
Yeah, there was a time, Nick, when we weren't able to provide phlebotomy on the Royal Berkshire site through our pathology provider, the Berkshire and Surrey Shared Pathology Service, because of the risks around social distancing. What we've done in the last, I think it's 3 weeks, this service has now been up and running, is introduce a booked appointment system. So it's there is capacity there now for people to get their phlebotomy appointment on the RBH site, just as they can actually at Bracknell and at West Berkshire if they have an urgent need.
So just one more comment about that. We did hear from a couple of residents that they were actually sent to, I think it was the Bracknell Health Space.
Yeah, that
when the services had stopped there. So
sure.
There was a bit about comms there, I think, again.
Yes, we've definitely heard that message. Thank you.
Okay. Jim Fruin again.
Sorry, Ken, it's me again, and Dom. On the question you asked about the drop in volumes into A&E, I can only speak from personal experience as a volunteer community first responder, put my teeth back in, and the number of calls that were not appropriate to 999 that we were sent on has significantly dropped. And I think that that's actually a good point. I think the calls that we're now getting are more appropriate to 999. So I think that may be one of the reasons why we saw a drop in the first wave, and I hope it continues.
That's very helpful to understand. Thank you, Jim.
Okay, I can't see any more hands up. Dom, can I thank you for that? That's been a very interesting answer and question session. There's obviously a lot of things out there which we all have to think about, and it would be quite nice if sometime in the future we could get you back, maybe in a quieter time. It's not quite so manic, and it'd be a pleasure to have you. So thank you very much. And you're quite welcome to stay in the meeting if you wish, or to run off. It's totally up to you. And we'll go on to the next item now. Thank you.
Thank you very much, Chair. Thanks for all the questions and the feedback. And I'd be very happy to join you on a future occasion at your convenience.
That's lovely. Thank you, Dom.
Thanks.
Thank you. Thank you very much.
Thanks, Dom.
Yeah, thanks, Dom.
Thank you very much.
Thanks very much. Bye.
Okay, we're going to now move on to the Healthwatch, item number 34. Now, who's doing this? Is it Nick or is it Jim?
Well, I'm happy to start. My colleague Joe's just joined us. So if there's any questions around the perinatal mental health report, that's probably the best place to start.
Okay, thank you. So we go after questions already around the report from the members.
Yes.
Members, do we have any questions?
Did anyone want me to do a summary of the report quickly before we see if there's any questions?
Yes.
Yes, please.
Thank you.
I think you should already have had a copy of it, but just very briefly, the engagement was completed last year, so pre-COVID. We had a survey asking women, well, it was parents within the Wokingham Borough, what their experience of perinatal mental health support had been, and we didn't distinguish between whether that was anybody who had a pre-existing condition or not. So we heard from people via the survey, but I also went around to groups, including the Children's Centres, NCT, and the BIBS support group for parents who've had babies in special care at Royal Berkshire Hospital. I also spoke to and did workshops with a project that was called Mum Zone that was being run between Wokingham Borough Council and Places for Leisure. So it was kind of lots of different approaches. We gathered lots and lots and lots of feedback, very detailed answers to surveys, and then went about making recommendations and looking at that very interesting information.
Thank you very much. Do we have any questions? Clive, would you like to start?
Okay. Thank you, Ken. Thank you very much for a very good report again, Joanna and Nick. I got a question here on page 4 of your report. So the in the top bar chart, the 3rd, 4th and 5th lines, they add up to about 30%. How many people would that be who were concerned that their appointment was being postponed or
I'm looking at page 4. There aren't any graphs on page 4, so I'm just wondering.
All right. So it's page 4 of your report, so it's page 22 of ours.
Would it be question 4?
I think you're referring to a different report. Whether you're referring to the COVID survey report rather than the perinatal maternity report.
Right.
So the perinatal maternity report was sent to members separately outside of the agenda.
All right. Okay. That was the one that you sent today?
No, it was sent a little while ago.
Oh, okay. All right. I'll wait till we get to this report then.
Thanks.
Sorry.
I was just looking for that report myself. I can't find it.
Yeah, sorry, I missed that one as well. Apologies from my side.
Yes, I've just been searching my emails and I can't find it in my emails. Do we know who it came from? Was it from Madeline?
Was it Madeline? Do we know where the report came from?
From me. I've forwarded it on.
Hello, it's Jenny here. I've got it in the agenda. It's part of our agenda, page 22 on our agenda, and it's page 4 of their report.
Let's have a quick look back there. Page 22, did you say?
Yes, of our agenda, and page 4 of the Healthwatch report.
Thank you, Jenny, because I was struggling there.
Liz, I think that's what he's talking about. I may be wrong.
That was my question, but I think I'm asking questions on the wrong report.
Yeah, I think we've got a few. Nick, do you know how many reports were shared from Healthwatch?
There was an updated one we had from Healthwatch as well.
Yeah.
I thought I'd sent those reports to Madeline. Because Madeline asked for those reports by the 6th, I think it was. And
Yes.
I think I sent them on that date, and you sent me a reply saying thank you, and you'd forward them on.
Yes, we've got in the agenda, we've got the GP website one and the COVID survey one, and then the perinatal one came separately after the agenda had been issued. So that's why that one's not in the agenda.
No, that's a separate one.
Well, I don't seem to have it in mind either. Okay. Yeah, it's difficult to ask questions around it, isn't it, if we haven't got the report. I'm wondering whether we can track that down for maybe the next meeting. And then we may actually have some questions for it. I'm sure it's an interesting one.
Yeah.
So, yeah, it's strange. Not sure what's happened.
No, well, maybe it's better then that, you know, the members have the opportunity to look at it, to ask the questions, because we were really interested in the feedback.
Yeah.
I've got up there. Like to go first.
Apologies, Joanna, because you've come along and we're not in a position to ask you questions.
Start for me. That's not Michael.
I will wait for. I'll wait for next time. That's fine.
Michael?
I don't know if this is the right place. Are we doing? I'm a bit confused now as to where we actually are. I got the Healthwatch GP websites report. Are we doing that at the moment, or are we doing that a little bit later on?
We have two reports in the agenda. This is not what we want for Joanne. It was something different.
Okay, so we got that to come up, have we, Chairman?
Yes, they come up next.
Okay, I'll hold my fire to then. Thank you.
Clive?
No, I've got my hand up waiting for when we get on to the COVID-19 survey.
Very eager.
Yeah, sorry.
Jim, was yours relevant to Joanna? Or
I have, Ken, if I may, and it's a general question, and I'm basing it only on the reports that are in the minutes. It would be good to understand how we select the respondees for the surveys. That's for both Joanna and for the other Healthwatch people. Having a percentage figure back of 46% is understanding how we pick the target audience.
So you asked who are those?
That would be useful if we could see that.
Yep. Okay. Who's going to answer that one?
Sorry, can you just clarify the question again?
Yes. If I look at the report we've seen, it talks about mental health. It talks about, we asked people about the state of their mental health during the coronavirus.
Yeah.
I'm talking about page 23, I think it is, of what, or 22, sorry, of what we've actually seen here tonight so far. And it was just trying to understand how we select the people to ask the questions of. You see where I'm coming from? If it's a random selection of residents, then that's one thing. If it's a number of residents that have already contacted us about other issues, then that's a different thing. I'd just like to understand that if we could.
Well, sorry. So this is on the COVID-19 report, isn't it? You're talking about, yeah. Okay. Do you want to answer that one, Nick, or?
No, carry on. Now you've turned up.
I'm going to say something now. I'm here.
I thought I'd make use of you now.
So the responses we had from that survey mainly came from just advertising the survey via our website, social media, and through local groups that we've got contacts with. We didn't specifically target any particular residents for that. It was a general survey.
Thank you. It's useful to understand how that came about, because you can get, if you invite from specific groups or known groups, you can get a bit of a skew on the data. Thank you.
Yeah, thank you.
Now, I think what I'd add to that, Jim, is I think I've said at previous meetings, the way we engage has totally changed because it's had to. And yes, we do target, a lot of it's been digital stuff, but we do target groups in the sense that where they have a digital platform like the learning disability groups, we would talk to them. But it is very difficult to get the same sort of mix that we had pre-COVID, just because we can't go out onto the streets and talk to people.
It's one of the reasons I asked the question, because I know it must have changed.
Okay, well, we've moved on then to the main report now. So, members, are there any questions around this report?
Yep.
And Clive?
Yeah. Thank you, Ken. So, page 22 or page 4 of the report, the bar chart that is at the top there, and line 345 comes to about 30% of the people who had decided not to use NHS and social care services during the first lockdown. How many people does that actually represent? Is it 30 people or 200 people or what?
So we're talking about what page, sorry?
22.
Page 4 of your report.
Yeah, or page 4.
22 in our agenda.
So this is the bit that says we asked people if they'd used NHS or social care services since March the 23rd.
Yeah, and then for those that hadn't, then you had these 6 reasons as to why they hadn't, because they didn't want to use public transport, they were worried about catching COVID-19, or the appointment was postponed.
Can we share the page for everyone? Is that possible?
I can't.
The title across the top is Using NHS or Social Care Services. And this is the first report, the COVID report that we're in. Are you able to see that, Nick, or is that?
Yes, so of the people who answered that, it was, so it's close to 30% of people said they didn't use the services because they didn't want to bother the NHS, or they were worried about using those services.
Yeah.
And that was of the 178 people who answered the question.
Okay. So it's around about 60 people who were saying that the appointment was postponed, or they'd wait until services got back to normal, and they didn't want to bother services during COVID-19.
Yeah, and I would,
to
extrapolate on that, myself and my colleagues from Healthwatch Reading and Healthwatch West Berkshire gave a presentation to the unified exec. So in total, across those 3 organisations, we had nearly 700 responses, which is incredible, really.
Yeah.
But the figures were very similar across Reading Healthwatch and West Berks Healthwatch.
Right.
So to me, that was saying that there was a large amount of people who just didn't go and get treatment, either because they didn't want to bother the services, or they were worried about using the services. And interestingly, last Thursday, I attend the, and that's the worrying piece about it, and Dom was talking about it today, the recognition that they know that people are worried about going and using NHS services. And in that flu action group, they rag rate it. So where are the issues in terms of people going and getting their flu jabs? And the big area they're worried about were people who've got a high BMI, had a really high refusal rate to go or just not turning up. And they said they needed to do some comms around that. And so I raised this point about the charts we're just talking about, saying, well, do you know, on the one hand, you're saying you should turn up because, you know, it could keep you alive. And on the other hand, they're going, well, I don't want to turn up because I'm worried about catching something, you know, so I just don't want to go to hospital or to a doctor's. Right. So we talked about very targeted comms about saying it's really safe to come. But Joe and I have talked about this, you know, it's the type of comms they're giving. They need to make people feel really safe, and they need to communicate in a way that does make them feel safe. But we know they don't always do that. And that's why I asked the question about phlebotomy, because the comms wasn't good. So we've seen this a few times, and I think I talked about it at the last meeting. So they need to do better around the comms.
Okay. All right. So I got a question for page 23, which is the following page, and your diagram in the top right hand corner. Would you be happy to have a video appointment again in the future? So that this is people who have had consultations via video, and we've got a result of 61% of people saying yes. So I think that is pretty good.
Yeah.
Does this save time, or does the setup time of the meeting to do it as a virtual consultation, video consultation, actually take more time for the GP or the clinician who is doing the consultation?
I don't know. Do you want to answer that one, Joe? I mean, it's hard to know. You know, we were just asking the question because we were interested.
Yeah.
Did you find that a positive experience or didn't you? And it's clear, and again, across the West, it was very similar figures, that a lot of people were very surprised how well it worked, apart from the occasional technical problems. Yeah. Where they had to revert to the phone. And the point we made to the unified exec when we gave the feedback, and some of that is in the appendices lower down, was some people were going, well, it worked really well, but others were going, well, do you know what, it didn't, and actually I want a choice. I don't want to do video consultations. I want to do it on the phone. I want to do it face to face. So it's, for me, a lot of that is about choice. You know, there's a danger here that they'll go, this is what we're going to do, you know, video consultations, and that's your lot. Well, actually, some people don't want to do that.
I would hope that they never actually do that they never say the only way we're going to have a conversation with you is via video. Future question, and then if I ask another one, then I'll give way for another person. So page 24, this is, please choose a statement that best describes how your mental well-being has been.
Yeah.
And the last line, the last bar, is I have had ups and downs. So could this be that it's just normal life, which is up and down for a lot of people, or were the people answering I have had ups and downs really thinking they've actually had more downs during COVID-19?
Well, that's a good question. In hindsight, you could always go back to these surveys, couldn't you?
Yeah.
And Joe and I have had these. We've had these discussions before. You could always go back and go, well, how could you have refined it? But I think that's probably a true reflection on the discussions I've had with people. You know, about. Yeah, well, you could read it either way. So we could have refined it and said, yeah, I normally have ups and downs, but during COVID, I've had more downs than ups. So,
yeah. Okay. All right. And then you've got a couple of Appendix A, and all of that is really good. And Appendix B, where could we have done better? I just want to highlight CAMS.
yes.
And that they've not been particularly organised and clear at times about the services and appointments, I guess, that are available. And that really is, I think, still very, very disappointing. And I really do think there's something has to be done to improve that service.
It's an ongoing issue, and I sent you an email, Clive, because I think you were going to attend was it health overview and scrutiny for children? And the big issue is ADHD.
Yeah.
And the 2-year wait. I don't know if you want to. Do you want to say something about that, Joe? Because we were chatting about that earlier, weren't we? You've seen it a couple of times on Facebook.
Yeah. So just, I mean, I would say this needs to have a conversation with CAMS directly, because this is sort of from service users, but also from the sort of voluntary sector, that during the last few months, that obviously the waiting time has gone up for CAMS, which you kind of would expect, I suppose. But we're recently hearing that CAMS have stopped accepting new referrals altogether. So obviously that's really concerning, and we need to find out more about that and what the process is going to be for restarting referrals at this stage, because there are a number of concerned parents. And of course, then you've got sort of 2-year wait already. Does that become a 3-year wait or a 4-year wait? It's concerning.
I just find it incredible, because it has such a massive effect on an individual child, and then any other children in the family as well. Has a massive effect on them. It can completely ruin somebody's life chances if they're having to wait for a few years.
And with all these things, we always know that the earlier the intervention is given, the more likely it is that it's going to be successful. So it's very hard.
I find that difficult to actually believe that they're saying the services just are no longer there.
I think you know what I'm saying is that at this point we haven't spoken to CAMS about what the situation actually is. That's what the understanding of these parents was, but we need to check that out before we say definitely that has been paused, that referrals have been paused at this point.
There was one line that was quite disappointing, and that was that people had to make a number of calls and send several emails to surgeries to get them to provide a shielding letter.
Yes.
And I'm sure that would have been very, very important for that individual person, because they were wanting to shield, or they were being told that they wanted to shield, but their employer was saying, give me the evidence that you are supposed to be doing this, otherwise I want you working either at home possibly or coming into the organisation. So a delay of several days or even weeks could have caused quite a lot of anxiety to those people who were having to work.
Yeah, no, absolutely. A couple of times we had to get involved and go direct to the surgery just because they couldn't get past the front door.
Oh, right.
You know, so one individual was saying, you know, I'm going to have to go back to work, and I can't go back to work. You know, it's like, So I need this letter. So there was a lot of toing and froing, and you shouldn't have to do that.
No, it's sad that you found that. Okay, thank you very much.
Rachel.
Hi. Yes, I just wanted to ask, on page 8 of your report and page 26 of our report, it says that there were a number of people who were fearful of accessing NHS services. Do we know if there were particular groups who were particularly affected by this and what their fears were?
No, we didn't ask the question. So I think if we'd done it again, you know, you would have elaborated on the question, but we didn't do that.
Okay, okie dokie. Yes, it's kind of concerning, I guess, isn't it? And my guess is that they were fearful of contracting COVID and therefore didn't want to go near any healthcare, you know, facilities. But yes, it would have been good, I guess, to know whether there were particular groups who were particularly affected by that. But I appreciate it's hard for you to look at everything. Thanks very much.
I think that would have been good to know in hindsight, yeah.
Yeah, but I think just going back, you know, going back to the flu thing, you know, and there's lots of people with high BMI who are declining to have the flu jab. So why is that?
All right. Thank you, Rachel. That's
Cheers, thanks.
Any other questions? Well, no. Right. Next is Abdul, please.
Thank you, Chair. Going back to the referral service which has been stopped, can I ask or suggest that you speak to Matt Pope, because it is quite concerning, or Charles, just to get an update what's really happening.
Yeah.
Is that okay with the rest of the committee?
I think so.
Okay.
Yeah.
Well, I thought it's, you know, we do that and come back. Thank you, Chair.
Madeline will make a note of that, I'm sure. Clive.
Yes, thank you, Ken. I forgot to mention Appendix C, which is 2 pages. And isn't it good to read all of these positive comments? And I think we should note that, because, you know, all of us can sometimes be a little bit critical of what's going on, but I think we should be really noting that there are just loads and loads. I haven't added them up, but it looks like sort of 50 positive comments here, which I think is very, very nice. So would like us to see that. And then my final question is on page 35 of our report, and it says key findings. The majority of websites did not contain information about what to expect if a patient needed to visit a practice, including wearing masks, social distancing, and whether they could be accompanied or not. Yeah. And so has that been addressed, do you know? And then the line below was only 50% of the websites provided clear information about how to book a telephone consultation. And has that improved? Because 15% is pretty low, isn't it?
Yeah. So firstly, Clive, I'd say Appendix C, we're really keen to give the positive news, you know, not that, and that's only part of it. So it was really important to include what was good, whilst highlighting what could be better. In terms of your other questions, it's gone to the CCG and we haven't had a response yet, so we'll see what the response is.
Okay. Right. Thank you very much.
But I would just add to that, you know, it just follows that narrative again when Joe and I and class, the learning disability group, did that mystery shop. it just highlighted again, you know, people are not getting enough information to feel safe. And if they don't feel safe, they're not going to turn up.
No. And you would think that by now it would have been quite easy to have put some guidelines on a website for.
No, absolutely. Right. You know, and again, it's things like.
I know they're busy. But
yeah, they could have made it much clearer. They could have made it much clearer. You can feel really safe. There's hand sanitizer. Make sure you wear a mask. You'll be greeted by this person. You'll be socially distanced. But there was none of that on those, or very little of that on those websites.
Yeah.
Is that right, Joe? If I got it right.
Yeah, absolutely. And I think, you know, the other thing that we were concerned about was that people weren't being told where they would be waiting. So I don't know if this is still the case, but certainly at that time during the pandemic, people would have been waiting out in the car park or outside in their vehicles if they had one, or queuing up, and that information wasn't there. So if you did have someone who was elderly or who perhaps needed a seat, that they would need to know that they were going to be in that situation, and it wasn't clear at all.
Yeah. Well, then, if they're having to go to a surgery, they're going to find it all quite distressing if they are.
But that could be avoided by just giving the information.
Just add to their distress, isn't it?
Mm-hmm.
Yeah.
Okay. Thank you very much.
And I think the one thing I'll just add on to that is that I'll send the link to Madeline, but I had a meeting with the CCG about the annual patient survey for GP practices. And when it was presented to me, it was from across the West. So Wokingham, Reading, West Berkshire, and it's very comprehensive. And some of it includes websites and reception and all that sort of stuff. What was really concerning to me was the number of Wokingham GP practices that appeared in the bottom 4 or 5 regularly. Wokingham Medical Centre, Woos Hill, Burma Hills, and then you'd get the occasion outlier, which was Wargrave surgery, which is always right at the top. So I'll send that because I think it might be worth asking the CCG to come in and talk about what they do about that survey, because I asked the question afterwards, what do you use this survey for? Do you use it to look at best practice, you know, to try and help improve those who are at the lower end? But I had no response.
No, I think that would be a very good thing to do.
Yeah, I would really like to follow up on that. You know, we do get residents talking about Woos Hill. You know, we're at Burma Hills, and we were at Rectory Road, Woking Medical Centre, and you know, we moved because it essentially stopped functioning. So I'd be very keen to follow that up with a meeting. You know, if Madeline can organise a meeting with the CCG to talk about that, because this is the front line, right, that everybody experiences on a day-to-day basis.
Okay, Jim Fruin now, please.
Thank you, Ken. Apologies if I'm jumping ahead a bit here, but are we also including the JJS report that we got from Madeline on a separate email in this review?
The one that arrived earlier today. Oh, yesterday, was it?
You're jumping ahead, Jim. Oh well.
I think the answer to that is yes. So, yeah, by all means, ask the question.
Yeah. Can I ask someone on that now, Ken, or do you want me to wait?
Yeah. No.
Okay, there's a couple of points in there. In simple terms, for those that haven't seen it, which I'm assuming most people have, it was a response to a request we said on how we can help. And there's a couple of points in there about helping other councillors to understand what Healthwatch is and isn't, and most importantly, sharing some of the reports that we actually go through with other councillors, or at least making them available for other councillors to read. I think we see from these meetings how much interest and discussion and debate they stimulate. And I think in this current times, I think it'd be good if we could find a way of doing that. So as a committee action, I'd like to understand if there's something we can do in that line.
Well, we have the reports all appearing in the agenda. It is open information. We'd need to think of some way just to communicate that to all councillors. With something. Madeline can always do a mail shot to all councillors.
Whilst we're on that particular point, the line says we would be grateful if our reports could be shared by councillors once released. So Jim's asking if we can send it to other councillors. Are we able to put any of the reports on Facebook? Or is that not wanted by?
I'm pretty sure you can, but I'm going to ask Madeline about that. Madeline, what's the situation with this data? It is all public information, isn't it?
If the reports are on the Healthwatch website, then obviously they'll be in the public domain, and obviously if they're in the agenda, they'll be in the public domain. So if Healthwatch were willing, they could be shared further online. That's obviously for Healthwatch to say whether they're happy for it or not.
That's maybe something for Healthwatch to consider then and advise us at a later date, rather than making a decision now.
I think my original point was how do we share it around council, because I think it's of interest, but I completely understand where you're coming from, Clive.
Yeah, I was just adding.
Okay.
Yep, thank you.
Lovely. Michael Foger.
Oh, thank you, Chairman. Yeah, sort of going back, we kind of mentioned this already about surveys. It's under key findings of page 35 and page 40. It's mentioned about the survey results that none of the GPs seem to include this information. I think going back, we've seen that there's a lot of positive comments as well as some negative ones as well. So it does, more of a comment, it does sort of concern me that they don't share this information to be transparent. As I think, like everything else, it is public money going into this, and I think the public should know what's going on, whatever the comments are. So it kind of gives the impression that they're hiding something if they don't put this information out. That's my concern. So it's trying to be as open as possible. And I'm just really wondering if that's sort of Healthwatch's sort of goal later on down the line. I just wonder if they got any comments on that, really.
I wonder if I can put this out to all the Healthwatch people we've got here at the moment, because we're quite lucky to have 3 here at the moment. And what is the situation with these reports we see? I know sometimes we get to see them early, and you wouldn't want them to be seen publicly. But is that right? Can we actually take these reports and further distribute, shall we say, to other people and users or other councillors?
Well, if I can answer for Healthwatch, I mean, our view is that we've created information from the public, and once it's been critiqued by service providers and have been allowed to make their comments, it should be shared with everybody. It's not a secret, and I think it's highly important. One of the challenges we do find is that and Nick can comment as well, but sometimes it can take an age for any of these service providers to react to our reports. Even and very often they will only react when we've almost gone to the point of publish and be damned, and we don't want to publish and be damned. We want to be publishing and being correct. And I just wanted to make that point here, that it's very much this information, once it's on our website, it's public domain, and sharing it on a Facebook or anything for us, despite saying, Clive saying, well, don't make that decision now. I would be making that decision now. We put it in the public domain, we stand behind it. We're happy to correct errors, but we will stand behind it. And one of our challenges is the follow-up and getting the reaction from the service providers. Sometimes we get it, but I mean, Nick can probably answer better to some of this, that we don't actually get a response in a reasonable time, and it's very often it's way too defensive.
Mm.
Yeah, so sorry, can I just come in on that point? I mean, what I'm actually commenting on, more than perhaps asking a question, is that the practice themselves are not sharing the surveys rather than anybody else. So
I agree.
I think that's, I mean, it gives the impression, I mean, if there's confidential stuff and all the rest of it, absolutely, you can't share that. But if it's a comment, a positive comment, I mean, you're definitely going to want to share those bits, but you also need to share the negatives as well, because if you have a load of positives and no negatives, then alarm bells are going to start ringing, I think. Maybe that's what they're frightened of, I don't know, but it's really to be transparency for the patients and the public out there to know what their GPs practices are actually doing. And I mean, they've got some good websites out there, so I can't see why they wouldn't do it.
Well, I'll respond to both of them. Yes, you're right, Michael, and it was picked up in the report. The fact that if you want to say something nice about us, then put it on patient choice. If you want to say anything negative, then call the practice. That doesn't seem right. The patient survey, the annual patient survey report, there's no obligation for them to put it on the website. That doesn't seem right at all, does it? And I queried that with the CCG, and they said, no, there's no obligation for them to do that. So I've spoken to the CQC about that, and they're going to be talking to the CCG about whether perhaps they should be obliged or encouraged, let's say, to put that on their website, because why wouldn't you?
Yeah.
And to answer Jim's point is,
got very quiet. Have we lost you?
Oh, sorry, back now. Sorry,
you got muted.
No. It does that sometimes just by itself. In terms of, and Jim's letter to you about, what you can do to help us, is the biggest frustration is we can make these recommendations and quite often we see nothing coming back from that. And it would be really good, I think, going forward, if we give you a report and there's recommendations in it, and we turn up at the next meeting, you go, what's happened? And we go, well, nothing. That you call those people back in, quite often the CCG, and go, why haven't you done anything about these recommendations?
Okay.
So it's the challenge, really. It's the challenge. This is what the local people are saying about these services. Healthwatch have made these recommendations. Why haven't you acted on those recommendations?
So to start with, then, we should be thinking about a way to put this out to our own councillors, at least, so they're certainly aware of the report, even if they just make a note of the summaries, so they've got.
Ken, I can't emphasise how important we think this is. The fact that the work that we do gets properly socialised amongst anybody who may have an interest in it. And I mean, we know you all represent Wokingham citizens, so everyone should be really interested in what we're saying and the responses we get as well. That was it.
Okay.
Can I put my hand up at some point?
Well, a number of Adhd, have you got?
Yes, please.
Like to ask a question on the same lines, or?
Yes, it is in the same line. Yes,
Then
thank you, Ken. Thank you, Jane. Nick, very much interested on annual patient report. Again, there is a question which I would like to ask our lead member, Charles Maggett, to come up with the answers, because if those surgeries are time and time again are coming bottom of the league, there is some question need to be raised. So especially as a Woodley representative, I have surgeries there, and I do have concern over that. So how can I access this from you, that a particular surgery which is coming, bottom of the list? Nick can answer that if you don't mind.
Sorry, say again, Abdul.
It's about the surgeries which is coming time after time in the bottom of the league.
Yeah, well, I'll forward the results to Madeline, and she can share them with you.
That will be absolutely. Thank you very much. Yes, and I'll take it towards the our lead member for this area. Thank you.
Thank you, Abdul. Jim Stockley, you still got your hand up. Do you wish to speak, or was that left over from previously? Right.
I think that was left over from previously, Chair. I mean, when you finish with Healthwatch, I'll just make a couple of brief points at the end, but not until then.
Okay, that's fine. I'll keep that in mind. Clive, Abdul, your hand's still up. Clive, now?
Yeah. Okay. Thanks, Ken. I just want to make a couple of comments about Jim's note that has come to us today, and I really appreciate Healthwatch being our additional eyes and ears and articulating our residents' health concerns, and I really appreciate the independence of Healthwatch. But I know that there are, from being on this committee now for several years, I know there have been a number of councillors who look at Healthwatch as a group of volunteers. And the interesting thing about Jim's letter is that he is drawing our attention to the fact that Healthwatch is actually a statutory body.
Yeah.
So we should make sure that it is funded absolutely properly. And I know I return to this on a fairly regular basis, but I do not want to see any reduction in Healthwatch's budget over the next few years, and if anything, I think that it should be put back to what it was several years ago, and even increase from that, because as a statutory body, there is probably quite a few things that they would like to be doing, but they can't because they haven't got enough money. So I think that all of us that are councillors should actually do our best to make sure that they get more money.
Agreed, I think. Okay, Adrian, sorry, a little bit late getting you in, but
no worries. Thanks a lot, Ken. This is really a question to the Healthwatch guys. I think, what we're seeing here is some really good challenges, some really good questions. I know that we've struggled a bit on today's call with having multiple reports, but my suggestion to you, my request to you, is to have one more report, which is a monitoring report that you present every time we have this meeting, which is something like the top 10 actions outstanding, whether they be on the CCG or whoever, or top 10 hot topics, whatever you want to call it. But then, we can regularly monitor the things where action is not being taken, where things are being missed. Where the example around the GP surgeries, I think, is a very good example. That should be near the top of the list. But I would like to see this all brought together into one single simple report so that we can consume it and forward this on if we need to other councillors or Matt Pope or whoever, and try and get some attention on these matters.
No, noted, Adrian. I think that's a really good point, to pull that together, and it's part of the challenge to who knows what's going on. So yeah, I agree. Together like that, and there are so many overlaying different services, and
and trusts and functions. And the Bob situation is perhaps going to make it a little more complicated in the short, medium term. I'm struggling to see the wood for the trees. We need a regular monitoring report with your top 10, biggest hitters on it.
Nick, I'm just wondering if that's something that could be added into the impact and outcomes report.
Yeah, no, it could be. And I touched on it briefly. It's like I go to things like the flu action group, and it could be, you just pull one or two things out of there, like, the people with high BMI refusing flu jab. So why is that? So that's something for me and Joe to do and go, what are these things that we're really concerned about? Because I agree, Adrian, you can't see the wood for the tree sometimes, and I think I know the system really well, but and we come along to these meetings and we're firing stuff at you. So yeah, we can definitely do that. I definitely think that would help.
That would be really, really helpful. Obviously, when an action is completed, when one of your top 10 is, we've got a clear action, it's been assigned to somebody and somebody's delivered an improvement in that area, we don't need to monitor it forever. But, the things that are, where the wheels are falling off, we need that in a coordinated list or report, not an overly long report, because it's going to reference other reports, right?
No, quite. And the bit that we're asking, when you said, how can you help us? Well, that's how you can help us, by if we're very concise about how we see the issues, and then you can do the challenge based on those issues that we're raising.
You need to make the ammunition and we can try and fire some of it.
Yeah.
Okay.
Agreed.
Madeline, could I ask you a question? Within the remit of the HOS committee, if we have a particular GP surgery that maybe has shown, proved to be lacking in one particular area, is it possible for HOS to actually send a letter to them, just asking them, well, I don't know, we want to do it politely, but can we actually question somewhere like an individual surgery, or should we always go through the CCG?
I would suggest you would go through the CCG initially. It's usually the standard practice.
That is okay. Thank you.
Particularly if you have concerns about more than one surgery.
Yeah. I just thought it might be a way to put pressure on a surgery, but maybe that's not our job to do that. Is the CCG really to do that? But maybe we can just push it harder with the CCG when we get those. Ask them to explain it. Rachel, you have a question? Then Adrian. Rachel? Are you there, Rachel?
Sorry, yes, I didn't unmute myself properly there. I'm sorry. Just following on from what you said there about doctors and looking at some of the comments in the report about dentists and the communication from dentists. Would the equivalent be to go to the dental body or to go to dentists' surgeries?
Dental body.
To the dental body. Okay, fab, thanks.
And Adrian.
Yeah, following on from your point, Ken, I think we do need to follow up with the CCG, but again, following on from Healthwatch, we need to get this transparency and this idea of transparency, into the mix as well. It's, we can't live in a society where we can only say good things about people. It has to be realistic, and we have to understand the areas where we need to improve, whatever type of organization it is. It's only, with the aid of Healthwatch that we can do this. And the CCGs and the necessary bodies actually forcing these organizations to be more transparent, which is essential. I think this is a very important topic. And getting also on the back of Rachel's point, I think we have an outstanding action. Unfortunately, this is again back to you, Madeline, to get the dentists in. Again, we had another story from a resident in the last 4-6 weeks about really struggling to get access to dentistry again. you know, we really must get something from the dentist guy, somebody from the dentists, to come into this meeting and to accept some of our questioning.
Well, I'll add to that again. I would really encourage that, and I said that at the last meeting. I got a response from the local dentist council to our report from the secretary, who said, "It's very interesting, Nick, but I can't force them to do anything." And I think they need to be challenged.
But perhaps, sorry to interrupt, perhaps Madeline can advise us on, you know, which body we can escalate to, whether it's the British Dentistry Association or whatever, or whether it's some sort of Public Health England or something. But we need to get some answers from the dentists in these areas.
I will chase that up again.
Thank you, Madeline.
Okay, no more hands up. I'm going to go to Jim Stockley now for his closing remarks.
Sorry, thank you, Chair, Ken. I just wanted to summarise just from Healthwatch's point of view, but I just wanted to make a quick couple of extra points. First of all, I'd like to personally commend both Joe and Nick and Neil Bolton-Heaton, who are, our dedicated workers on this, because what we're doing, of course, is, as Nick has alluded to, is we're doing without our standard and preferred operating practices, which is talking directly to people. So the fact that we've been able to pull together as much information as we do is as much down to them as anything else, and I wanted to acknowledge that. And I also I would add, we're going to continue to investigate and follow up on the work we do anyway. So we regard that as an ongoing activity for us. And I think just going back to a question I think Clive was talking about, which is about GPs asking, how they feel about video surgeries all the time. I think that's a damn good question for the CCG, actually. They surely should be checking with their own constituents as to how they feel about all of this. So that might be an interesting question to pose to the CCG. How do GPs feel about it? I'd also just like, and unfortunately Don's gone, but I can vouchsafe my neighbour is a regular at the phlebotomy clinic, and he very much likes the new process of an appointment and attending. And I wanted, unfortunately, I couldn't throw that bit of good news in time. I'd also add, where those of you who remember, we used to put a column into the Wokingham paper, and we'll be starting that again, not on a weekly basis, but a monthly basis. So we'll continue to look to have our voice heard that way. And that was it. I mean, I think you've seen the letter I wrote. I mean, we are grateful for the support we received from the HOSC anyway. There's not much more I can add to what's in there. As I say, we are grateful. We're all Healthwatch volunteers by appointment or by proxy. So we'll look to you to also tell us where we should be looking as well. That was it. And as ever, thank you.
Thank you very much. Nicholas, did you want to come back in? No? Excellent. Adrian, do you want to come back?
Yeah, just further to what Jim was saying, I think it's great to get into the written media, the newspaper, but I think it would be great if you could do some pre-packaged things for social media, so that you can just forward them to the HOSC committee, so that we can send them on to Facebook, like to, I don't know, Evandon's or Woos Hill communities or whatever communities. But I would be happy to retransmit.
Adrian, I'm literally going to bite your hand off for that, because
Joe and I are both smiling, because I was about to come on to that. I thought I've spoken enough, so I'll leave Joe to it. And this is about just exactly what you've said, but also about the question about how you can help us. So away you go, Joe.
So we at the moment, our project that we're working on is to do with hearing from carers, unpaid carers, about their experiences during the pandemic. And we've put together a package of exactly what you're saying, Adrian. So suggested Facebook posts, tweets, something that could go into newsletters, something that could go onto websites, photographs that could accompany. And we've had in the past, when councillors have shared our Facebook posts, really big numbers of people responding. So I think, you know, you all really have that gift within you to get our work seen by more people and to make people aware of what we're currently thinking about and where they can get involved as well. So we would be very happy to send you by email our package on carers, but equally it'd be really interesting to have all of your Facebook handles, because then I can keep in touch with what you're sharing and we can sort of link up on more things, I think.
Yeah, so I think it's a question for Madeline. How can we do that best?
I think if we can send, if you have already on links that can appear on people's sites, if you send those links through to Madeline, she can distribute it out to the members of HOSC, certainly, and we'll understand what you want us to do with them, so we can get them added to Facebook sites and others maybe.
Yeah, and I think it's, you know, as Adrian was saying, sharing on the different community groups, that's really helpful. That's really boosted our ratings in the past.
So what we're trying to do is engage in a different way, and it's not all digital, because we've relaunched the paper thing, you know, in discussions with the paper. And we had a really good discussion with Involve today, who the voluntary sector group who pull everything together, and they said, oh, had you thought about the faith groups? Well, no, we hadn't. So it's just how we all want to do the same thing, don't we? Which is hear what our residents have to say. So it's like, how can you help us to do that?
I think that one of the nice things about Facebook is when you, if you do your presentation carefully enough, when these things appear on Facebook, people start talking about them. And I think that's probably why you get the wider response as well, because people suddenly realise you're there. So, no, I think that the right thing to do is, if we can get something across to Madeline on this, Madeline, if you could word it very carefully when you send the email out to remind us why that comes through to us.
Yeah, no problem.
Because quite often I look at something, I think, oh yeah, why did we ask for that?
But also, just to finish, it's not just about the HOSC, you know, which are brilliantly supportive. It's about the other councillors too. So we understand.
No, quite understand. All right, Nick. Doesn't look like there's any more questions. Can I thank all three of you tonight for, as usual, excellent presentations, which we all appreciate very much. And just thank you for coming in to the meeting. Thank you.
Thank you as well.
Thanks very much.
We will now move.
Yes, thank you.
Thank you very much.
Thank you, Chair.
We will now move on to our next item, which is the forward programme. Next and last, the forward programme. Madeline, do you want to take us through that?
Yeah. Sorry. So you've currently got two items. Sorry, my agenda's now gone with my ID. So our next meeting is in January.
Yes.
And we've currently got two main items on there, which is an update on the Woking Borough Wellbeing Board and the Hydrotherapy Services consultation. Since the agenda has been published, there's also been the meeting of the Children's Services Scrutiny Committee, where they had a presentation from CAMS, and they've made a recommendation that HOSC looks at a couple of issues, namely anxiety and depression, how that affects particular groups and in particular locations. and there was an issue regarding Willow House. One member asked whether it be the same type of services provided and numbers of young people being placed out of area. So you may want to have that at the next meeting in January. However, I would suggest that's quite a big topic. So if you were going to do that, I would suggest moving perhaps the update on the Woking Borough Wellbeing Board to March's meeting, and that might also help you get a general picture of the municipal year if you have the Wellbeing Board in March. Also, obviously, coming out of this meeting, you've got the request that we have the CCG in, and we had previously asked that they come in to talk about the pandemic and how they've been working with the council in the pandemic. Unfortunately, they weren't available tonight. That could also perhaps, if we get them in for that, encompass a discussion regarding the GP surgery survey. But again, I think that's quite a big item, and you wouldn't necessarily want to have that on the January meeting. So again, I would suggest to either have that at the March meeting, or you schedule an extraordinary meeting in between if you feel that March is perhaps a little bit too far down the line.
How do members feel? I'm certainly happy with that particular move. I don't want us to forget the unscheduled topics we've got at the bottom.
No. See, in terms of the unscheduled topics, the self-harm hospital admissions, I think, would be encompassed in the CAMS discussion. Certainly, looking at the minutes of the Children's Services discussion, that seems to have been flagged up in relation to depression and anxiety and self-harm. So again, that's an issue that could be included in that discussion. In terms of the council's response to COVID-19 and public health, I think there was a general decision that because obviously we're in the second wave, that whilst we will get them in, they will be a bit further down the line as they're obviously responding to the second wave. But it's not that we've forgotten them. Okay, well, the two that I'm interested in are the self-harm related hospital admissions and also the suicide prevention. So those are the two that I think we've put off long enough, if you like, and we could certainly do an update on those. As to how heavy those subjects will be, I don't know. Adrian, did you?
Yeah, sorry. I just wanted to support your thoughts, that we don't want to miss the unscheduled items either. And the CCG and the GPs, I think, is a really crucial one because, Woking consistently appears near the bottom of the surveys. So I would propose that we try and address that in an extraordinary meeting in February so that we could slot it in within the first quarter of next year.
Okay.
Yeah, I could certainly arrange that if the committee want that.
Sorry?
How about the other councillors? What do the other councillors think? Everybody's quiet.
No, I fully agree with it, what Adrian said.
I think it may be a case of some of these things that we want, we can actually move to the unscheduled area, not the one you just mentioned, Adrian. I think that's quite important. But don't forget, we can put things in the unscheduled and leave them there for a period of time while we wait for time to become available on the main agendas. So what I don't like is to see them there for a long period of time, and the suicide prevention, for instance, has been up there quite a while, so that needs to be brought to the forefront. So there's not a problem with doing extraordinary meetings should they be required. The problem is normally getting the people in that we need to respond to it. I don't want to have an extraordinary meeting only to find out that we've got no one to actually talk. So.
Yeah, that makes complete sense, Ken, obviously, but the dentist as well, I still want to see the dentist.
Yeah, we never got a person at all from them.
What I would suggest is that for meetings you would probably not wish to have more than 2 main presentations.
Yeah.
So certainly for the January meeting, I would suggest that you stick with your hydrotherapy consultation and so potentially the CAMS issue, and then as Adrian suggested, in February you have your CCG and GPs, or you could have the self-harm and suicide, because suicide I think would be a separate presentation to self-harm. So that may be one where you have 3 if you want that at the January meeting, if that makes sense.
Yeah. I think
you may wish to start earlier if that would be amenable to members.
The hydrotherapy one, we can't move that from January, because in December the CCG, I believe, are making a decision about the hydrotherapy pool service and whether they're going to continue with that. So that will be quite key at that point. We can. I'm wondering if we should leave the just put the GP one into the March meeting, and then put the dental one back in the unscheduled topics, and we'll decide in January whether we should put that into the next meetings. Would everyone be happy? Oh, well, we've got a couple of people waiting to speak. Clive, would you like to speak?
Yeah, I probably should have taken my hand down, because all I wanted to say was I think we should have an extraordinary meeting in February, and that's the way you're going. So that's fine with me.
Michael?
Yeah, I'm very much like Clive, I think, and Adrian, going for some sort of meeting in February that obviously the people that we need, the invitees, can actually turn up to it. Obviously, that's got to be important. But yeah, I mean, I think that's the way. There's a lot of heavy subjects there. You want to give them a good review and a good overview. So yeah, if that's the way to do it, I think that's the way you're going, Chairman, and obviously other members as well. So yeah, I'm all for that, and particularly the hydrotherapy, which is going to be a big news item one way or the other. It's something I'm particularly keen, to see what RBH come up with that one, because we don't know at the moment.
It's not RBH actually, strange enough. It's actually the CCG that.
Oh, is it CCG? Oh, right, okay.
Withdrawing funding.
Oh, right, okay. I mean, I'm new to this HOSC, so it's my first meeting, so please excuse me. Okay, thank you.
All right, look, so in that case, so where did we get to on the January one, Madeline? Are we going to do the? So
in terms of January, please someone correct me if I've misunderstood. I've now got the what I will call the CAMS item, but under that includes the issues around depression, anxiety, the self-harm in that particular age group, which is currently in the unscheduled, and the question regarding Willow House. The question regarding Willow House may be a separate briefing, because that's NHS England rather than Public Health or the CCG. And then also suicide prevention, which would be a separate item, and the hydrotherapy one. So that, I think, will be perhaps a bigger meeting. And then in February would be, hopefully, should people be available, the extraordinary meeting for the CCG and the GP patient surgery. Then in March, you've got the Health and Wellbeing Board update moving from January, and dental issues moves to unscheduled, and hopefully we can fit them in when they become available.
Okay, that sounds good to me. Does everyone else, anyone object to that, or any better ideas? Or okay, we'll go with that then, I think. Thank you, Madeline. That's great. In that case, we've now come to the end of our meeting. Thank you very much for your
Chair, if I might, sorry.
Go on, Jim.
I've got a couple of proposals to put to the committee, following on from what we've heard tonight, if that's possible.
Yeah.
So the first is, I'll take my hand up. The first is that the Wokingham Communications Group are sending out regular COVID updates now, with some general news in there as well. And I know that the sort of messages in there would actually lend itself to us supporting the RBH request earlier on about making sure people attend appointments. I think I'm proposing that as a committee, we ask if it's possible to get that message included in the SEM, the communications messaging.
Okay.
How members feel about that?
So do no harm to ask, will it?
Good idea.
That's a good idea.
I think everyone's great. If we can organise that, Madeline, that would be great. Thank you.
And secondly, if I may, Ken, sorry, the Healthwatch messaging that we sort of spoke about at length, I just wondered whether it's possible to either ask the leader's statement to include a quick comment on that, or whether we can actually put in a committee report for inclusion at a future full council, just giving a very, very brief update on Healthwatch and what it's doing, and a recommended reading list towards the reports without taking too much time up at full council.
I don't really want to overcomplicate it. It's much easier if we get an email together, which we can send out to relevant councillors to.
Yeah, even better.
That's correct. Yeah.
And I think to take that to full council is, but I suppose a lot of people will say, well, hang on, why? You know, whereas we can explain.
As I say, they're just proposals, so I'm just whether other committee members will support.
How does everyone else feel about that? I think it's better we did. I think it's better that we do our actions first.
Exactly.
Yeah. All right. Oh, okay, Jim. So we'll take that approach then. Yeah. Having said that, we can always consider something should it be necessary later. But I think at this time it's probably our own actions that can probably make that work for them quite nicely. So on that note then, I now close the meeting. Thank you very much for giving us your time. And a special thank you to Madeline.
Super. Thank you very much.
Good night, everyone.
I enjoyed being an observer tonight. Thank you.
Thank
you. Good night, everyone.
Hello, Malcolm.
Good to see you.
I've also survived my first HOSC as well.
Oh,
yeah. I'm usually in the meeting rather than just observing it. But good night, everybody. And the genial chairmanship again. There you go.